Okay, and I am not seeing, okay. I need to turn on the sound for later. So I am going to share that. Okay, so the system of care data dashboard was the topic that we had. So I'll go ahead and introduce myself. I'm Hilary Harris, and I'm the system of care policy strategist for OHA, so the Child and Family Behavioural Health Unit. In a former life, I was working with the System of Care Advisory Council in the setup phase for that. And so I had a lot to do with the original creation of the data dashboard. So it felt like my baby at the time, but I have handed my baby over, and my baby now lives with Anna Williams over in the System of Care Advisory Council, and I'm across in OHA. So Anna, do you want to quickly introduce yourself?
Sure. Thanks, Hilary. My name is Anna Williams. My pronouns are she, her, and I am the executive director of the System of Care Advisory Council. We can talk more about that, but we've already done that in this meeting. And I want to, not to correct Beth, but just to give credit where credit is due. Hilary did 99.9% of the work to create this dashboard, and this resource and tool that you all are learning about today is pretty amazing, and the work that she did to pull it off. I mean, there's no way you can understand the amount of challenge that Hilary surmounted as she went through this process. So just want to make sure that she's getting credit for her amazing work as you are all looking at this resource that she built for you.
Well, thank you, Anna. So Anna will talk in a little while about the system of care and some of the pieces. What I wanted to do was just to start with some background, again, as Beth said, around the Child and Family Behavioural Health Unit and our focus within this. So this is our new visual, for those of you who haven't seen it before, for children's behavioural health in Oregon. And you will see on this the mission of our unit is to champion effective and efficient statewide behavioural health services, supports and safety for Oregon's children, young adults and their families, incorporating system of care principles, developmental science and trauma-informed practices. And you can see that over on this left-hand side. So we're on a mission, but where is that mission taking us to? And that mission is taking us to, on this side, what the System of Care Advisory Council has established as a vision for us all, which is a future where young people from all backgrounds are healthy, safe, learning and thriving at home and in their communities. And so you can see that with any good mission, it goes along a pathway. And we have 4 strategic pathways that we talk about, which sets up 4 strategic areas that we're looking at. And importantly, underneath all of these are 3 foundational pillars for where we're focusing our work around health equity, youth and family voice, and trauma-informed principles. So that's kind of the background. And if you look at our strategic pathways up here, we talk about the continuum of care and how we develop that and enhance and improve all of the continuum. There's then, again, a lot of work around youth and family engagement. And the third piece of this is how we establish data-driven decision-making for Oregon, to really help us to understand what's happening within the children's system, so that the services we provide as children's behavioural health really match well with what's needed, and we understand the impact that we're having. Our 4th pathway is around cross-system collaboration, because we know that we need to do this together in this system of care way. So that's the big picture for behavioural health in Oregon. Our 4 strategic pathways, I've just said again here, are the continuum of care, youth and family engagement and data, with our aim being that work centres health equity in making policy and programme decisions based on accurate and timely data, and by seeking data that can assist in understanding health inequities. So today's presentation is all about how do we understand how the system works, what's happening, and one of the ways that we can do that is through the data dashboard. You heard Beth talk about the other things that we're also doing that are related to that. And so in terms of this data-driven decision-making piece of the Child and Family Behavioural Health Plan, what we're looking to do is increasingly structure our data collection, evaluation and analysis. We want to look for those gaps. We need an overview of the data, so you'll see some kind of dashboard be created by our unit at some point that starts to look at how the things that we're measuring. We want to make sure we're communicating that outwards so that people like yourselves understand where everything's coming from in terms of behavioral health. And then we want to look at some specific systems issues and project needs and do specific research into that area. So in a minute in the chat, we have just created our first performance indicator report, and you can find that on our website. It runs 54 pages of collected information, so it may be of interest to you to go in and find information that we've collected on wraparound, and I believe there's some MRSS in that. We also put some national things into it so that we can nationally norm Oregon against behavioral health to really look at how well are we doing against some other things. We would recognize that a 54-page report is really a little much for most of us to take in. I generally get bored by page 10 and can't quite finish it and have to go back to it, just being transparent. So the next piece of work is how do we sort that performance indicators into key performance indicators. And so we're going to be engaging in some work with OHSU, and I'm pleased to see Amanda is here from OHSU today, but they're going to be helping us by setting up an expert panel of statistical gurus and others to really help us work through what do a lot of those things all mean when you pull it together, and what are the things that they believe as Oregon we should be looking at and really watching to tell us about the health of the system. So that's kind of the big picture to it. And then we are going to come into talking about the data dashboard, which is a really big component. And as many of you realize, it's years since, or I don't know if ever we've really been tracking a lot of how systems work in a very intentional way. And so the exciting thing about the data dashboard is that it starts that process. So with that, over to you, Anna.
Thank you, Hillary. So quick description of, again, what is the system of care? There are sort of two versions of what the system of care is in Oregon. There is the sort of capital letters system of care, which is the System of Care Advisory Council and its connections to the local systems of care that are convened by each CCO region. There are multiple CCOs in some places, so one CCO is the lead in that system of care work, and I'm happy to connect you to your local system of care coordinators if that would be if you haven't already connected to them. But then there's also sort of lowercase system of care, which is a philosophy that describes a range of services and supports that are supported by a specific infrastructure. So you can build that infrastructure in a variety of ways, but it is looking at cross-system collaboration. So not just the state agency level, but the community-based partners, non-traditional partners, like looking at faith-based providers for respite, for instance, in communities where that makes sense, right? So it allows regionalization and tailoring to make sure that youth are able to stay at home, in school, and in the community to the greatest extent possible. And when they need care, that the care is provided by providers that work for them, whether that's through some sort of affinity or through some sort of specialty, that they have access to the services and supports that they need to thrive. And the infrastructure is a process that allows us to coordinate the different child serving systems. One of the differences of the system of care philosophy and model is that most services are built and designed by professionals using data and best practices research that comes from universities, which removes the folks who are making the decisions from the lived experience of using the services. So the system of care philosophy and structure requires that people who are creating the system are in constant collaboration with people who have experienced the system and ideally are experiencing the system currently, though that's very challenging for some families and youth, so that we can build a system that's actually responsive and serves people's needs instead of what sort of we think would serve people's needs and be responsive. Beth?
Just a question is there a difference between system of care and continuum of care? So there's Hillary's answering in the chat box as well, but it sounds like, sometimes we know people use those interchangeably, those two words. Can you just elaborate on that? And Julie just came on screen, whose question it was.
Thanks, Julie. Yeah, so continuum of care is sort of all of the different services and supports that that people should have access to or people do have access to. So it's more the program side. System of care is the collaboration structure and the processes by which we build connections and increase communication between the players in the continuum of care. Is that clear enough? Yeah, okay. And they often are used interchangeably, but they are not actually the same thing. So thanks for asking for that clarification. And then the last thing I'll say on this slide, Hillary, is that the System of Care Advisory Council's priority is folks who are involved in multiple systems or should be involved in multiple systems, but haven't been able to access those services because of some barrier, whether it's an assessment or not having providers that do that work in their community or something else. Next slide, please. So one of the cool things that the System of Care Advisory Council, thanks to Hillary Harrison, was able to create was Senate Bill 1 in 2019, which created the System of Care Advisory Council, required that this data dashboard be created and had some very specific data that it wanted to have shared. So it currently exists, and we'll show you the link and go through it a little bit. It displays data for young people involved in child serving systems. So right now we have DHS Child Welfare, DHS Intellectual and Developmental Disability Services, the Oregon Health Authority's Behavioral Health. So that's through contractors. The Oregon Youth Authorities, that's either in custody or getting care through contractors again, and County Juvenile Justice. We are working to incorporate education data into this dashboard as well, so that we can get an even more nuanced picture of the experience of these young people. We know that folks who are involved in these systems are whole people, whether they're involved in one system, two systems, or three systems. So we're trying to, or four. So we're trying to really get a picture of what is the service experience like, and how does policy affect that over time. Some important things to note. Numbers in small counties are suppressed to ensure privacy for youth who might be identifiable. If you were able to sort of click through and see, oh, there's only 3 kids in Morrow County who are, having this experience, and this is their demographic data. There are updates periodically to the data. So while it's updated every 3 months, and it's at each 3-month update, it's a 3-month lag. It takes about 3 months to clean up the data and process it and make sure that all of the different system data are matching appropriately and correctly. They will sometimes go in and have had a Medicaid review or something like that and say, oh, some of these data are in the wrong place. So there will be times when there's like a separate chunk update due to lags in claims processing. So, and then back to what we're hoping to bring in for academic data. We're looking for information about academic achievement for students who are in foster care, focusing on English language arts, math, attendance, and 9th graders who are on track to graduate or not. We are looking for students who are experiencing houselessness. We know that schools often have much better data about who is currently experiencing homelessness and who's at risk of homelessness than what the point in time count provides. Discipline and dropout information, again, with using the demographic information to see if there's disproportionalities in those populations. Special education services and eligibility, so gaps between folks who should be getting and are getting special education supports. Early learning, preschool and pre-K, who's involved, what are their demographics, are there geographic differences, and alternative schools and alternative education experiences, again, to sort of be looking at how are these kids who are in this population connected to whether they're involved in the juvenile corrections facilities, whether they're involved in child welfare, are we seeing disproportionate outcomes for youth who are systems involved? Next slide, please. So the system of care outcomes measures were created in consultation with System of Care Advisory Council and a woman named Liz Manley, who's a national system of care expert. And they did a strategic plan, which is available. I can paste the link, I think, into the chat. They created a strategic plan for the System of Care Advisory Council that incorporates our work with those local councils that are connected to CCOs. And these outcomes are looking at what do we want the outcome of our cross-system collaboration work to lead to. So we want all youth to have connections in their community. We know that that's one of the most important things for youth to be able to thrive. We want youth and families to know how to access care when they need it, and to have access to diverse providers who look like them or who they identify with in some important way, that they can feel comfortable to get care from them. All youth graduate from high school. All youth have a plan to continue education or a vocational plan, and any identified services and supports are available to them to move into their post-high school life in a way that they can be productive and feel successful. All youth have necessary independent living skills. All children and youth have a home and a place to live on their 21st birthday. Children in child welfare custody are served in the home whenever safety permits. The juvenile justice system is not used as a gateway to behavioral health services, and youth or young people involved in multiple systems do not, after the age of 21, enter the adult correctional system. So if you look at these outcomes sort of as a whole, they have a significant emphasis on prevention. So we're looking at opportunities to prevent involvement in later sort of downstream systems like child welfare and juvenile justice. The first 7 outcomes on this list look at how we're doing in things like building social cohesion, providing access to culturally responsive care, and focusing on social determinants like education and housing stability. The last 3 look at, unfortunately, we know there will continue to be failures in the system for some time as we build on this work and improve. So in failures of the prevention system, we want to be monitoring what happens once kids do become involved in systems like child welfare and carceral settings, and how do those systems end up affecting their outcomes later in life. Next slide, please. So the System of Care data dashboard is available on the System of Care website, and I believe the link is in the slides. Is that correct, Hillary? I can paste it in the chat because we will be needing to hop over there to play around in a little bit. So there it is in your chat.
Yes. And so would you like me to show the video now?
Yep.
So do you want to, normally we show the one the sum is greater than the parts. Are you wanting to show both of the videos?
No, I think the sum is greater than the parts is the most helpful one. And
Okay.
I think the one you already had pulled up, right?
It is the one I already have pulled up, I hope. So hopefully that is now on the screen. Is that correct? Did I pull something new onto the screen? Yeah, okay. It wasn't just sharing the, okay. And we will press play and hopefully you are getting sound.
ORI, Office of Reporting, Research, Analytics, and Implementation.
You will find in the System of Care dashboard that the sum of groups of people are often greater than the total people. This occurs when a person appears in multiple age groups, physical locations, services received, and other data, during the time data are captured on the person. Let's demonstrate how this can happen. We'll use age in our example. Here we have 10 people and 2 age groups 0 to 9 and 10 to 17. On January 1st there are 4 people in the 0 to 9 group and 6 in the 10 to 17 group. On January 15th a person had their 10th birthday, thus falling into the 10 to 17 group. What this means is that between January 1st and January 14th you would see 4 people in the 0 to 9 group and 6 in the 10 to 17 group, and if you looked at January 15th you would see 3 people in the 0 to 9 group and 7 in the 10 to 17 group. What happens if you look at all of January? Then you will see 4 people in the 0 to 9 group and 7 in the 10 to 17 group, for a total of 11 between the two groups. This is because one of those people fell into both categories during the month of January. We hope this simplified example of how one person in 1 month of data can fall into 2 age buckets helps you understand the concept of the sum of the parts being greater than the whole. This same principle applies to other categories in this dashboard, such as physical locations and services received, regardless of the duration of time shown in the data.
Thanks, Hillary. So just to you maybe get in there and looking, and since some of you are like incredibly familiar with service provision in your area, you can break the dashboard down into CCO regions or counties. And so you may like, oh, I know we only had 10 kids, but we're showing 11 in this. Why is that? This is your answer, right? And because the data is updated every 3 months, there's some movement between birthdays, between placements, between even kids. Sometimes some systems identify demographics simply by looking at a child, racial demographics. Other systems ask kids their identities, and those identities may change over time as youth become more connected to one family member or another, or as they learn more about their family history. And so you'll see some greater than the parts in demographic data fairly regularly. And that's nothing to get concerned about, but if you do have questions, do go ahead and reach out to myself or Christy Hudson. I think the next thing we're asking you to do is go ahead and click on the link and check out the dashboard. You'll see up on the left-hand side, you can select for system, so behavioral health, child welfare, developmental disability, or juvenile justice. You can select by CCO or county just below that. If you click into the menu, there'll be a pull down that gives you options. And each time you'll see sort of along this all youth served and behavioral health, you'll see the numbers change. What's really cool is that you'll also see that little blue line change because it actually updates that little graph. You can hover over the bar graph. So youth who are in home and community down here where it has, I think, 63,000.
Sorry, I was just showing people the actual dashboard, which may be helpful.
Oh yeah, and you do have to click through a few disclaimers at the beginning
and then
before you get to the actual dashboard.
And bottom right, you can increase it here so it goes to full screen mode, so it's more comfortable to see.
So, and then Hillary, if you can hover over down there where it says in home and community, you'll see that it shows an additional breakdown of what types of placements are people in. So that it's just an incredibly rich tool that you can. Hillary, is there more to say about how you would recommend people try to navigate and learn what's available in the dashboard?
Just notice you can change the age range at the top. You can change the date range at the top. Just double check you've got that. It tends to just always go back and check those before you do anything else. And that you can, when you hover, you get these tooltips that give you the full data underneath it. So if there is data to be had, if you click on one thing, it's going to become the focus and it will change everything in the dashboard so that you can narrow down into questions that you might want to answer. So, and if you click it again, that disappears. And you can then choose to filter by any of these up at the top. So if I just want to hover, look at behavioral health, it's now added that behavioral health line, and you can see that in the lighter blue. And if you're stuck, then if you click on information or you want to know, it's going to tell you about the information. And then it takes a second. And if you want help, it puts an overlay and it's going to explain each of the things. So again, it repeats the sum of the parts or whatever. And hopefully those hovers, that help button is when you're looking at it going, what does that mean? It can help you get through that. It's also probably important, sorry, I was just thinking the other important thing is the glossary, just because we have the whole aim of it was to be cross system. So we group child welfare and juvenile justice information together around some of the placements. And so in the glossary, you get a really clear this plus this plus this is what is in a certain category. Okay, Anna, what were you going to say?
Beth was starting to ask a question.
Oh, I was just curious if we had a chance just to make this make sense with the work that these folks are all doing. So I was just thinking if there was if you could show us, say I was in a specific county and I wanted to know how many kids, can we see on here how many kids in a certain county were seen in the emergency room for behavioral health based on age? I think that was one area. For MRSS, I know one of the things that we're looking at is if MRSS is able to reduce the amount of kids who are seen in the emergency room. And so that's something like bigger we're trying to piece together. So I'm just curious, Hillary, if you could show them, if they were in a specific county, how would they look and use this to make sense of what they're doing or help inform the work that they're doing in the mobile crisis?
Anna, you want me to go ahead and walk through that?
Sure.
Is that okay?
Yeah.
So is there enough time for that?
What I did was I moved from the overview into behavioral health, and you can have analysis or you can look at the demographics. You can choose here male, female. Again, you can look at age range and you can go to specific ages, whatever you want to do, and a date. So at the moment, this is set for 12 months, which is actually February through January, which is the last time we updated the dashboard. So you can choose, for instance, let's go in here and just choose Benton County. You can do multiple selections. So you could do Benton, Lynn, and Lincoln, which is IHN land, but I could do, oh, and I've clicked that one, sorry. And so that is now selected. And so it is showing you here the number of youth who was served in the emergency department in Benton County. So you can see that there were less than 10, and if you hover over it, it'll give you 6 were saved there, 6 served in July, and then nobody in the other months, October, November, December. They're not showing up there, they're zeros. If it's less than 10, it generally has no line at all. And you can see that it's saying that 743 young people received behavioral health services, and giving you that data. The gray behind these percentages is the graph over time. So you're getting an impression of how many with experiencing developmental disabilities, what percentage of those were served by behavioral health.
And this is Medicaid OHP youth only, correct, Hillary? We are not able to access private pay or insurance information for this dashboard.
So that is how you do it. And you can also do it for fee for service. And if you want to pull in onto just child welfare youth, you can do that. So that is how you navigate the dashboard. If I look at the demographics tag here, it's going to tell you the difference in gender, the numbers in each age group, and then you can start to look at race and ethnicity. Anna, we wanted to give people a chance to play with this, so I'll come back out and go back to the presentation. There you go.
So go ahead and click on that link with the soc-dashboard.aspx at the end of it. That will take you to the dashboard yourself. We have some sample questions. Hillary, if you want to click to the next slide. To sort of get you started, obviously, if you have other questions you want to try to answer, go ahead and try to navigate through the dashboard to get those questions answered if it's relevant to you. Hopefully it will be more fun to click through and try and answer your specific questions. The sample questions that we have for you in December of 2022, how many youth from 0 to 25 were in 3 or more systems? You would find that on the overview tab. How many youth age 0 to 17 were in the emergency room across all of 2022? You would find that in the behavioral health tab. And statewide, how many 18 to 21-year-olds were served by child welfare across the year of 2022? So, and then Julie is asking, who's included in fee for service, not enrolled in a CCO? So Medicaid eligibility is not an expertise that I have. Hillary, do you have that answer?
I'm sure Beth does, but tribal members, sometimes it's people who have adopted youth and they end up on fee for service. They don't get tagged to a CCO. Those are some of the primaries. Are there any others I missed, Beth?
Those are the main categories. Our youth, tribal youth are fee for service. They're not attached to a specific CCO, and they're managed by the state. And then also youth in foster care or adopted often sometimes end up in that category.
No, it's not. It goes in a served program like cats. It's a
small number of youth. Yeah,
it's a very small
youth.
part of the OHP population. Exactly.
Yeah.
Yes.
So if anyone would like to put their numbers into the chat when you've had a go at this, if you're struggling on any of this as to how to change ages or something, please let us know and we can do one on the screen. But we thought it was important to give you a chance to explore from your perspective the dashboard and discover hopefully how easy it is to use to find some useful information sometimes when maybe you have a presentation you need to make or someone's asking you questions about, so how many young people are there that you've served? So the first question was for 2021, how many were multi-system involved? And so if I pop out to full screen again, it takes a while to jump. So that was the overview page, I believe. And this was over here in this box. Do you see this? This is how you tell how many were multi-system involved. And then to change the date range, you go here. And I go to, did I say December of 2022? And so I'll just take it back to December 31st. And so that is showing the, oh, I've got the wrong year, haven't I? But not to worry. We'll go to, I'm like, that sounds really large for a, okay, the number went down. In December for the whole of Oregon, we had 211 who were multi-system involved, excluding education, as Anna says, which we know is probably the biggest one and the one that we're really interested on getting added into this. So you can see that, oh, I should click off behavioral health. Maybe that'll increase it, it won't, but there you go. So that's the numbers for December.
For 0 to 17, yeah. So Andrea just noted if you change it from 0 to 25, you'll see a higher number, of course, which 0 to 25 is the population of focus for system of care. As Beth mentioned at the beginning, some of our services go through your 26th birthday and some of them go through your 21st birthday, but we were really focusing even on transition age youth as they're moving into adulthood and looking for stability.
Okay, and here you go. I added that 21 to 25, and it gives you a breakdown of, if you hover on it, it did for a second there.
It
now
did for a second,
it
disappeared.
I clicked the bar instead of just hovering, so it then gave me all the detail. So if I just hover over the bar, it should give me the numbers for each age group. So for those of you who are interested, this is a really good way to think about your young adult population, to come in here and pull up some of these numbers, because it is surprising how many of our young adults are showing up in places like emergency rooms and in these numbers in larger ways than many of us expect. And so it's an interesting window on understanding our system. So
and then just pointing out that the next box over that has youth served by 3 or more agencies, it shows you which agencies they're involved in by which ones are blue, right? So that matrix, you'll see that fewer than 5 youth were involved in all 4 of the agencies that are included in the dashboard. 178 were included in behavioral health, child welfare, and intellectual developmental disability services. That's by far our highest 3 service population. Then you'll see behavioral health, child welfare, and the juvenile corrections system at 41 individuals who are involved in those 3 systems. Behavioral health, IDD, and juvenile justice at 21. Child welfare, IDD, and juvenile justice are only 9, which again, we can assess a little bit and think that's probably good, right? That those are only 9 kids who are not receiving behavioral health services. If you're involved in all 3 of those other systems, it's highly likely that you need some sort of behavioral health support. So seeing a small number there is a good thing.
And one of the questions that we've never been able to answer before the dashboard was how many young people are experiencing developmental disabilities end up with behavioral health involvement, and when is that happening within what happens to them. And so this dashboard starts to answer that question and shows us that actually our young people with experiencing developmental disability do receive services at a proportional rate to most of the others in a similar way. So was there another, can you see the questions, Anna? Is there?
Yep.
On
the next one was how many youth age 0 to 17 were in the emergency room for all of 2022?
So going to the behavioral health page, clicking analysis, the emergency department numbers are over here. You'll see it didn't change. So I need to change the dates here to the whole of 2022.
Yep.
Okay. So there you go. You can see the graph that shows you the whole of the year. It doesn't actually give you a total, but you can get an impression that most months there are over 200, somewhere between 200 and 250 young people who are in an emergent, or almost 300. That's 294 for October with the highest numbers. And if any of you are interested, on Wednesday afternoon at 2, if you receive our emails for the Child and Family Behavioural Health Team newsletter, we've got a community conversation around the use of the emergency room based on the numbers for 2022. And so if you're interested in joining us, you are more than welcome to do that. I'll attempt to put the link in the chat in a minute, but we have looked at all of that and have it broken down by counties as well, around the usage of emergency rooms across the year and ED boarding.
And Julie Majors is asking, I think LOS means length of service. Does it give length of service for all levels of care? And it does not. We are not able to track length of service.
I think she's probably talking about length of stay in an emergency room.
Yeah.
No, it doesn't.
I'm actually talking about length of stay in any of these settings. We don't know that, right? From this data.
No.
Okay, thanks.
This is claims data, so it doesn't give us length. Again, more data is needed. We know that we would love to be doing more to understand those things. Beth, did we miss anything? Is there anything else you want us to cover with this? I mean, we can look at some more examples if people are interested. If you want to let us know in the chat if this is useful to help you to learn how to navigate or think about this dashboard, happy to do some of the other examples.
No, I mean, I'm more curious to see if this is helpful, if people are like, I can't see folks, if people are actually digging around and looking at numbers for their counties, or if, people are playing with it, if people have found any information that was interesting to them already. I would just open it up for people's impressions of this, of the dashboard, and just open it and see if anyone has anything they'd want to share about what they've found so far, or anyone digging around on their county and find anything interesting, or
Another thing this is useful for is grant applications. Being able to understand priority populations and the numbers and using it as a citation to say, we're focusing on this population because we see this many people who are involved in these service mixes. I've been doing grant reviews and I get really happy when I see that folks have used the system of care data dashboard and to identify their priority populations for their activities and their grants.
and again, it's a part of the picture because these folks are serving all Oregonians, regardless of insurance or insurance type or existence of any insurance whatsoever. And so it sort of gives you a little bit of a glimpse, but not the whole picture of what you all are seeing out there. Any other questions you all have for Anna or Hillary before we kind of conclude this? And we'll spend the last 30 minutes sort of, there's some questions that people have emailed me about mobile response and stabilization services that we can go over. Can I just see a thumb, can some just thumbs up? Do people think that this might be helpful, or they might come back to this at some point in time to do more exploring? Was it helpful to learn about this tool? Anyone? I know you guys asked me how I choose how the topics get chosen. So I'm just curious if this was a topic that you all are interested in or feel like this might be helpful down the road.
I think it's great. I'm sure it'll be referred to pretty consistently at the state level, and we'll be like, where the heck did you get that?
Yeah.
So well, it's nice to know it's available.
I appreciate that, Jackie. And I also just think keeping eyes on, I'm most interested in, how many kids are showing up in, for me, into the emergency rooms. And if over time we see that number, are we gonna, is mobile crisis, how does mobile crisis start to chip away at that? And there are certain age groups that we're better at implementing outside of the emergency room. And are there other age groups that end up being referred to the hospitals or the emergency rooms more often? I mean, I think that that's interesting too.
I think I'd just conclude by saying the information that you're getting to Beth and to OHSU is just so vital to us understanding the system. I end up picking up a lot of calls from family members these days, and I can't tell you, the people who've moved from out of state arrive looking for MRSS these days because it's happening elsewhere, and they are so desperate to get help and connected and know that if they can get these early interventions, that they can help their young person and stop bad things happening. And so the implementation of MRSS is just so vital to the health of our system and healthy Oregonians that I can't tell you how much I'm looking forward to seeing the implementation really happening on the ground, and for us to be able to tell the stories that we hear from all these other states of the dramatic transformation that this makes to children's behavioral health. I mean, every time I'm on a call, they're talking about the closure of juvenile units and the the way things are going better for young people in school, and just the almost wild difference that this intervention makes, that, you know, I can't emphasize enough how important it is that we get this work done and that we're tracking it. So again, we can tell those stories to the legislature and to others to, again, understand that and be able to, again, tell our story nationally and celebrate with others that we're finding the same things that they are in, making a difference.
Stacy has a question. Go ahead, Stacy. Stacy's from Clackamas County.
I was just wondering, with so much data being tracked, how do you draw a correlation for any of these things? Like you're talking about, you know, is mobile crisis going to have an impact on emergency department visits? But you're also looking at juvenile justice, child welfare, the state of the world. You know, and I get a little nervous sometimes when we have a lot of data that we start like throwing around, but it's not necessarily directly correlational. And so sometimes it gets misused. And that is kind of like a nervous for me when I start seeing like, you know, well, emergency rooms are still going up, so mobile crisis isn't being effective. But those two things aren't necessarily always linked.
Absolutely. I mean, I can tell you just from a global perspective, I agree with all of that, Stacy. And I think that we have to be very careful at how we decipher and interpret data and be know the limits of it. That's the first thing. The other thing too is it is really hard. It is really hard to know which pieces of the system are impacting or like drawing those conclusions. And I don't know like what level of like how many years will it take for us to see the results that some of the other states have seen who have been doing MRSS for like 15 years? So us looking at the first quarter versus in 10 years a retro, and then what else is going on in the community that may be impacting them. So it is really a complicated sort of process, which is part of the reason we bring OHSU in, is that the research people that look at those things and are able to pull apart sort of at a higher level. But then also, I guess the last thing I'll say is also just knowing that the work that you guys are doing on the ground, every person you come in contact with, like each of those individuals that you guys are spending time with, and that you guys intervene and keep them from having a family, from having to go to the emergency room, or only going to the emergency room once and getting them in stabilization services instead of 4 times. We sort of look at the individual, the micro and the macro, but yes, we have to hire people to look at that data to make sense of it for sure. I don't know, Anna,
yeah, I mean, yeah, Beth, it's like we ensuring that we have people who like OHSU and others, we're, you know, having conversations around assessing right now, hiring contractors to do some of that sort of what is connected and what isn't connected, and what are those other factors out there that are impacting changes in these lines, right? Because you're taking a whole community's experience and you know, drilling it down into one, you know, piece of data that really loses a lot of the context around it. So data integrity is something that we take really seriously, and trying to be clear about what the data tells us and what it doesn't tell us, in terms of, you may look at this line moving and assume that you know why that is, but it's really, there's a lot more going on, right? And so to some extent, that's why we're trying to aim this dashboard at folks who have some level of data understanding, right? That what you can infer and what you can't infer. We've also made some changes to the dashboard where people were making assumptions that were inaccurate because of just how it was presented. So trying to be thoughtful about not telling a story that isn't real. And then ongoing periodic deep dive assessments on, okay, was MRSS the thing that changed this line on the dashboard, or was it one of 6 things that changed that line, right? And so those will be issued in reports through Child and Family Behavioral Health or through the System of Care Advisory Council, so that where there is real correlations that are important for us to understand, that those are articulated explicitly. I would say in general, avoid making assumptions that the data is connected to something, because really there's so much behind the scenes to match the data, that it loses some of its specificity, and so making assumptions about what it means can be dangerous.
Yeah, I think for the children's programs, especially, like we had that in IIBHT. A lot of you guys also do IIBHT. Is, you know, is it what happens when a child discharges to a higher level of care? So if you just look at that, sometimes the numbers, I'm like, we have to really dig into that, because maybe they already had it to go. They already had, like, they knew that they were going to end up in detention for 30 days because they were in the process. And so that looks like they went to a higher level of care because IIBHT couldn't meet their needs, but that's not really the true story. The true story is that they kept that child from reoffending or getting more criminal justice involvement, knowing that they did their work in a time limited and that it's not as failure that they stepped. But if I just looked at where they discharged to, it doesn't tell me the full story. And so Stacy, I think that it's really complicated, and I think we look, and part of why we have this learning collaborative is because I often hear you guys tell me things that doesn't get reflected in the data, or doesn't correlate. And so then that also gets me curious to go back and be like, well, they told me that they're doing the X, Y, and Z, but we're seeing this in the data. So where is the disconnect? And can we actually draw correlations between what I'm hearing is going on and you guys are experiencing on the day-to-day? How does that go back? So my brain also is sort of playing that medium, and why I feel it's so important to have these learning collaboratives, to have the people boots on the ground, the folks who are doing the work saying, yeah, we've seen X, Y, and Z trends. Like we're seeing tons of, I don't know, a while back in IIBHT, they were like, we don't know what's going on, but we're only serving 12-year-olds. Like all of our referrals are for 12-year-olds. And we were like, well, is that really a trend? Is it specific, or what's going on with 12-year-olds right now? And a lot of it is speculation. But having those conversations and thinking outside the box gave us some areas to explore and go back. So. Well, I know data collection isn't everyone's favorite, and I know that we do ask a lot of you all. And so I just appreciate you guys sort of looking at how what we do on the day-to-day sort of gets filtered all the way up to the top into the work that Anna and Hillary are doing on the system of care advisory, and that work at the global level. So I appreciate you guys coming today to share with us. And Hillary, thank you so much. I mean, it is true, Hillary did put in a lot of blood, sweat, and tears to get all of that cross collaboration between all of the different people to release information and get it into a place that, again, that video that they showed about the sum parts of the sum, I mean, it is true. We still want to make sure that we're asking questions when we see the data and getting curious about it and not just accepting it as, at face value, because there's so many variables. All right, so for those of you who just, thank you, Anna and Hillary, you're welcome to stay and hang out with us. We're gonna leave a little bit of time if people have specific questions. I've been getting a lot of questions about MRSS and just different components of it. And so I wanted to address some of those and leave some time today. If those folks were just joining us, I made a announcement. I'm gonna stop recording. Recording. Hold on here, I want to stop the recording.